All right, here we go. As we talked about, chemistry, cancer, and stuff like that. People are getting treated because they're living longer, so advances in oncology care and stuff. So you'll be seeing radiation injuries. I know for a fact that, like St. Francis 9th floor inpatient rehab, patient will go down and get radiation treatment, and then they'll come back for physical therapy after the fact or a day later. So, radiation basically is use of harmful effects of ionizing radiation to treat the disease, which is usually cancer. They're just zapping you with radiation. So if you want to just go down to the power plant in Savannah, Georgia, just go stand in one of the reactors, you're getting radiation. But what it does is, radiation basically prevents cellular reproduction or replication. It's keeping it from multiplying over and over and over. But the parts you as therapists have to be aware of, arterioles are damaged, resulting in inadequate nutritional supply. Ischemia. I know the full-timers know that. Where's a part-timer? All right, tell everybody what ischemia means. Stand up, show how tall you are. There you go.
Reduced blood flow.
Bingo. All right, so they just have reduced blood flow, or there's not blood flow here because the arterioles are damaged. And it's usually in the irradiated tissue areas. It's not like they're going to shoot you in the neck for cancer and your feet are going to be ischemic. It's going to be generally in that area. So you as a PTA might have a patient with radiation pneumonitis. And that's because you'll have interstitial inflammation because of the reduction of gas exchange, because of the arterioles not exchanging through, this goes way back, osmosis and all that kind of stuff. So what they're going to have is shortness of breath. The medical people want to change SOB to something new. It'll always be SOB to me. Which is kind of nice. You can go to a patient somebody you don't like and say, you're an SOB. They confess that. It usually occurs approximately 2 to 3 months after completion of radiation therapy and typically resolves in 6 to 12 months. So there's that time frame. Everything overlaps. You can get it right away. You can get it later on. It can last long. It can last short. And then for you outpatient people that have radiation therapy for cancer, you'll see them more because they're going to be weak. And the doctors usually order outpatient physical therapy to get into better shape, or to get back into shape, get stronger, and then you'll be dealing with this stuff here. What you'll see in a patient is like sunburn. So I know nobody in here does tanning beds or lays out in the sun a lot. So you'll have a grade 1 reaction, which resembles a sunburn. Grade 2, persistent erythema or patchy moist discolorization. In other words, your skin starts to peel off. There's a grade 3, which will be pitting edema, is usually characterized. If you don't know what pitting edema is, that's basically swelling that's real thick. If you put your thumb into a swollen area, you take your thumb out, there's still a dent in there. That's just the pitting edema. A lot of times you'll see that in your ankle. Probably all of you in here will get it because you're sitting down in a dependent position. Your legs are down. So if you have tight socks on or something of that sort, when you take them off, you'll see all these little reaches and stuff. So that's pitting edema. All right, grade 4 are severe with skin necrosis. Sometimes we want to do that because we want to kill that skin. So like a melanoma, that's what they would do to kill that area. And then here's immediate and delayed effects of ionizing radiation on page 23 in your book, table 2.3. Just give you a little bit more general ideas or other information in regards to radiation injuries. All right. Unfortunately, some people have to get radiation and chemotherapy. sometimes they just do one or the other, but sometimes they have to have both. So, chemotherapeutic agents doing the same thing. They inhibit cell division by chemically messing around with your DNA. That's a great spelling question. Spell DNA. No. The real words for it. All right, over 75% of patients receiving a combination of chemotherapy experience nausea and vomiting. They will throw up. It's a given. And as they say, God forbid any of you have to have that stuff. But you may have run into people that have had it, whether you volunteered or you know a family member or friend. All right, and here's the side effects of radiation and chemotherapy. If you're getting a combination here. And the biggest problem is if they do it over the stomach. So kind of your, colorectal cancers, your gut cancer, anything in that regards are going to have the most effects. Implications for physical therapy. So this is going to be when you're treating a patient that had radiation. Here's the long-term complication of radiation to the brain. So your patients will have this, so radionecrosis of, basically of the brain. So you have headaches, cognition changes, personality, etc. That's kind of the saddest part, but you kind of learn to live with that while you're talking to someone, and it's really not them anymore. You know them as a certain thing, and then all of a sudden you come in the next day and you're like a totally different person. If you're pregnant, avoid contact with patients' internally implanted radiation devices. That's the biggest thing. If you're pregnant, stay away from that stuff. And that's being the therapist is pregnant. These patients are susceptible to infection, so observe good hand washing. We killed their DNA. We're killing their immune system. So you always want to keep yourself clean. Bless you. Also, this is huge too because you're in charge of this too, positioning, because you're the one who goes into the room, bed mobility, exercise first, bed mobility, sit to stand, transfers, and maybe gait training. And then usually you put it back in a chair or you put it back in the bed. Well, you just want to make sure how you position them because you don't want to give them bed sores. So avoid positions where a patient is lying on the target area, which will be marked on his skin. They give you a little tattoo. It's usually a dot or a little X, something of that sort, because that's where they're going to be getting hit with radiation. So just make sure that they're not laying on it. Also, avoid strong sunlight, heat lamps, and thermomodalities. There you go. Modality people, you're not going to want to put a whole hot pack on them or in that area. Technically, you don't want to put it on them at all because their arterioles are damaged. They can't dissipate the heat. He's just going to stay in one area. Now, the fun part for you personal trainers, early aggressive range of motion exercises. They're going to feel crappy. They're going to feel weak, fatigue, all that stuff. But you got to move them because if you don't use it, you lose it. So, can prevent loss of function caused by adhesions and scarring after radiation. We're killing stuff and it's going to scar down, so you want to move them. So, aggressive range of motion, that's exactly what it means. Move it, they're not going to like it, they're going to scratch you, they're going to yell at you, they're going to slap you, but you got to make them do it. Physical therapy for the chemotherapy. Research shown people recovering from should not be instructed to rest. I love that part in the hospital, and you probably all dealt with it. They put me in the hospital for rest. No, they didn't. If you rest and you don't get up, they're going to send you to a nursing home. Threaten them. So you got to get up and move. So don't be the therapist that's. We work with one, or Jeremy can mention that one too. We work with one that walks into the patient and she goes, "You don't want to have therapy today, do you?" Of course, we're going to send you back. She just wants to get away with it.
Wow, you look really tired today. Do you need more rest? Do you need to get you up?
Yeah. Then we work with a therapist, Kim. I love her. She don't take no for an answer. If your arm fell off, she don't care. You're getting up. And she literally forces them up. So you're allowed to do that. They slap her, kick her, swear at her, complain, and all that stuff. But you're getting up and moving. The funny part is after you're done, they sit down and think, well, I feel better now. So, prolonged rest and decreased activity coupled with sleep disturbances or too much sleep can contribute to increased fatigue. How many of you try to catch up on your sleep on the weekend? Don't you feel worse? Or you take a nap before you go to bed? That's my favorite. I gotta take a nap 3 hours later and get up and go to bed. So it just drains you. Too much sleep will make you tired. Then again, not enough sleep will get you tired too. So you want to be alert for any infection, so you're always looking for that. That's one thing about therapists. You have to look at the whole body. If they have just a knee problem, you got to look at the head and neck. Instruct the family on prevention of bed sores or ulcers, contractures, proper positioning. Because you're only seeing them 2 times, 3 times a week for half an hour to an hour. Well, they're at home a lot more. Well, what are they going to do when they get home? Or in the hospital, you treat them in the morning, and in 24 hours, they're just in the bed. So you have to tell them to do stuff. Or we just call it, home exercises. When I'm not here, you're in the hospital, every commercial do this, this, and this. And you just hope that they do it. Then expect mood swings. They're going to be happy or depressed. Does anybody run across that with anybody? 1 minute they're happy, next minute they're depressed. You or somebody else?
Well, no, my granddad had cancer and he got really angry.
Okay, there you go. It's understandable. And the hardest thing for all of you is your first reaction is to fight back, but you can't. Because believe it, if an argument ensues, nobody wins. Ladies. Unless the guys are smart. They just say, yes, dear. Then you walk away cussing them up and down. Right, David?
Yes, sir.
All right, now, that's the nasty stuff. Now let's talk about the fun stuff. And all of you are in this boat too, believe it or not, even at your young, healthy ages. Your fluid and electrolyte imbalances. Very important. So these slides, put lipstick on it, put a big kiss mark on it. You have to know this. Not only for testing, but also for real life stuff. So sodium. Once again, if you look at the IV thing and you start reading the label on that stuff, it's Gatorade. But it has sodium in there, and it has certain measurements in there. So, the main thing about sodium, it affects the osmolality of blood. So it influences blood volume. If you don't know what blood volume means, look it up. Make sure you know it, because the sodium is going to deal with that. So, 134 to 145, God, I always forget what MEQ is per liter. So, when you're doing chart reviews, bless you. God, I'm sneezing again. What'd you do this weekend? Study? Allergic to words. All right, so now let's talk about with the sodium. You could be hyper or hypo natremia. Natremia, I don't know how that means sodium, but it does. All right, so if you have hypo, you're going to have decreased sodium in your blood, of course. Without sodium, you're going to have muscle twitches. Just think of Parkinson's. It's not Parkinson's, but you know how Parkinson's people twitch. Or how many's had that little muscle twitch in your eye? Something to like that. They'll have circulatory collapse or hypotension. So if they're hyponatremic, you can take their vital signs. You'll see their blood pressure, because orthostatics, if they stand up, that blood pressure drops, they fall down. They'll have respiratory difficulties. So they have cyanosis. They're going to be that nice color of blue, pale blue. And the skin will be cold, clammy, or have turgor. Turgor simply means like when you're dehydrated, you pinch it and it stays like it's wrinkled and then it slowly stretches back out. So that's what turgor is. Now, inversely, hypo is bad, but hyper is bad too. So if you have too much sodium, so you McDonald's eaters, French fries, salty foods, and so on and so forth, you're going to have circulatory congestion. So you have pitting edema or excessive weight gain. People have a lot of sodium in them. You'll be hypertension. And of course you'll have tachycardia. Your heart's just beating real fast. Mainly because your blood pressure is high, so it just has to pump faster and get blood out because you have circulatory congestion. They'll be agitated, restless, and have convulsions. You hypernatremia? No, not yet. And they'll have a flushed skin. They'll just be red. That's because of the hypertension and all that stuff. So they look like a little beet. The reason this is also important is, for you as therapists, you need to know this because there'll be a diagnosis that says, patient has this, also hyponatremia. And you're going to know this is what you could come across. So you're going to have your safety precautions, your precautions and contraindications. All right, potassium's another big one. 3.5 to 5.5. It's to maintain function of the sodium-potassium membrane pump. Potassium is for your muscular activity. And guess what the most important muscle in your body is? Your heart. Plus, includes your organs and skeletal muscles too. So it's also your GI tract. If it's all messed up, if your potassium is messed up, you can't poop. Or you poop too much. So, you can be hypokalemia. So low potassium is going to be obviously muscle weakness, fatigue, and leg cramps. So, believe it or not, you runners, long-distance runners, or people like that, they start to cramp. Well, that's because your potassium levels went down, so you're hypokalemic. You'll have postural hypotension. That's your orthostatic hypotension. In other words, what you want to do is take blood pressure laying down, sitting, and standing to see how much it changes. You'll have arrhythmias. So your heart is sending off crazy signals. In other words, it's not going to be that QRST wave. It's going to be, instead of being that smooth, it's going to look shoddy. Respiratory distress. So they'll have a tough time breathing. Bed mobility. Supine to sit. They may huff and puff. Or they may pass out. They'll be confused, irritable, have depression. But also they'll have nausea and vomiting. Now, if you're hyperkalemia or hyperkalemic, you'll have muscle weakness also. You have too much, but now you become flaccid or you're paralyzed. Or have paralysis. Paralyzed is not the right term. You just have paralysis. You can't even lift your arm up to below your nose. Well, lower extremity, so you can't move, you cross your legs. You'll have tachycardia followed by bradycardia. So your heart rate's going to go real fast and it's going to go slow. Fast, slow. It just doesn't know what to do. You have nausea and vomiting. And then here's what we talked about, the EKG looking crazy. You'll have a flat T wave, prolonged QT interval, and a brisk ST segment. I would highly recommend, as you're studying, when you see anything that involves EKGs, kind of Google it, just so that next semester when we get into it, you'll have a good idea what T waves, QT interval, and all that other stuff is. All right, so potassium is, well, they're all important. Now let's talk about calcium. 4.5 to 5.5. It plays a role in the electrical excitation of cardiac cells and mechanical contraction. So calcium is important for your heart also. Whereas Potassium is for the muscle. Calcium is for the electricity in you. So you could be hypo or hyper calcemia. With hypo, muscle cramps, tetany, and spasms. Because your electrical system isn't running smoothly. It may jut on too quick and you'll go ahead and have spasms. Or tetany where you just start shaking. You have numbness and tingling. And I think if you have cramps, tetany, spasm, numbness, all that stuff, you're going to be anxious. So all of you right here don't have hypokalemia. You're just plain anxious because you have a test tomorrow. Well, for the full-timers. If you're hypercalcemic, decreased muscle tongue weakness and flaccid paralysis. Your electrical system is just not working. It's kind of shut off or you unplugged it. The scary part is respiratory muscle paralysis. They literally can't breathe. So they'll hyperventilate or they just stop breathing and it's a medical emergency. They'll be lethargic, confused, have decreased sensations. And there's what we talked about, bradycardia, your heart slows down. Basically, you unplug them, and you have cardiac arrest. So if you see a diagnosis of hypercalcemia, be on guard. Depending on the levels, a lot of times the doctor just says hold treatment. All right. Now let's talk about the etiology of imbalances. How do you get these things? Oops. So, dehydration, that's the big one. How many drink water every day or drink? Okay, good. How many drink beer? No, I don't care about that. Biggest thing is, you Southerners, how many drink sweet tea? Not good for you. It gives you kidney stones, gallstones. It'll dehydrate you. How many drink half and half? Half sweet, half regular tea. Basically, you shouldn't drink tea at all, or drink it within low amounts.
But what's worse, tea or soda?
Both of them are bad.
But you had to choose. That's
You had to choose. Choose neither.
No. Choose sweet tea. That wasn't an option.
Well, it all depends. If you drink sweet tea, I've seen people drink a gallon a day. I mean, if you just have like a glass or two a day, that's fine. But if you're a slug and you drink 2 glasses a day and you never move from the couch, well, you have a problem. I know you're not a slug.
Yeah, I don't know. Some days are better than others.
So, dehydration. There's an inadequate supply of body in the water from fluid loss or inadequate intake. You can have fluid loss by being sick. When you run a fever, you're burning off the fluid, so you're getting dehydrated. Or you drink sweet tea, or you're too darn lazy to walk to the water fountain. I mean, I'm thirsty, but I'm not that thirsty. Dehydration, here's the bad part. You'll have diminished blood volume, hypovolemia. Literally, it looks like syrup. It just gets really, really, really thick, so it can't flow very well in there. So what happens is you'll have vascular collapse and shock. So what happens is if you think fluid, or thick fluid, it's going to go, but then you're going to have that little break in here. So in other words, the blood can't flow through fast, so everything just collapses. And dehydration is frequently seen in the elderly due to poor nutrition. Bingo. Older people just don't eat. They don't eat like they used to. Or they don't want to. Why elderly turn into vegetarians and get dehydrated. And here's what you do when you check them out. Here's all the signs of dehydration. Okay, and here's the skin turgor that we talked about here. You just kind of pinch it, and since there's no fluid, it just doesn't flow back out. All right, the etiology would cause, the causes continue on. You're going to be learning a lot about burns in this class. So, Loss of plasma through the burn. In other words, your blood just isn't normal blood if you get burned. Surgery. You have surgery. Sometimes you bleed a lot. If you bleed in turn, it's not like you're bleeding outside the body. Diabetes. Any diabetics in here? Type 2 starting diabetic? Good. Malignancies, of course. Any acute alcoholics in here? Not yet, huh? And dietary insufficiencies or excessive intake of sodium. Where's my Burger King, McDonald's, Chick-fil-A people? I hate all of you. Oh, there, thank you. Or pizza. Has a lot of sodium in it. So your medical management, this first one is important because you have to document it when you treat. Maintain fluid balance records. You're going to do intake output. You don't have a big sign on a door, do IOs. So, in other words, if you go in there and that patient asks for water or a drink, you give it to them, but you see how much they drink because you have to document it. If you ever worked in acute care or been in a hospital, sometimes when they have to go to the bathroom, whether it's bedside or the regular toilet, they have this little bucket in there that has little graduated cylinders in it, and it measures how much output there is. So if they got to go pee, you got to measure it. Or you look at it, just write down what it was and let the nurse know. Or you put it in your documentation. So I.O. is very important for you as therapists working in the acute care, subacute, if you're working in the hospital or nursing homes. There's a decreased fluid volume. IVs are administered to replace fluids. The reason I brought that up is because you don't want to unplug the IV all the time, or if you do and exercise them, make sure you plug it back in. Or more importantly, as you walk, if they're going gait training, you're walking with the IV pole. And then if there's an increased blood or fluid volume, diuretics. Good gracious, they just want to pee all the time. They do a bed exercise. You got to go to the bathroom. You got to get them up from the bathroom. You go for a walk. 5 feet into the walk, they got to go to the bathroom again. Anybody take diuretics? Has anybody ever taken a diuretic? Pee a lot? In the mornings there. There you go. All right. So here was what we talked about earlier, the implications for you as therapists. I.O. records are kept. So you have to watch what they drink, how much they pee. Wound drainage. You might have to measure the wound, how much fluid is draining. If they vomit, you got to measure it. Observe for swelling, especially in the distal extremity. Oh, you're going to see that a lot with the older people. They got these little fat. They have no angles. It's a calf and a foot. Encourage elderly and debilitated patients to drink frequently. Sometimes you say, "Here, drink." I don't want to. Drink anyway. Bless you. I've even seen nurses come in and say, "Okay, it's time for your pills," and it's a sugar pill. It's a placebo, just so they drink. Because they have to wash down the fluid, or the pill. Then patients who have congestive heart failure or severe renal disease limit their fluid intake. Congestive heart failure is the same thing. Your lower extremity swells. You get just fat feet, fat ankles, fat calf. So here we go, what you were asking about. Caffeinated fluids and alcohol cause fluid loss, so discourage those. So that's what you're talking about. What's the worst case between tea and sodas? They're both not that great for you, but to answer her question, I'd probably go more with tea. Of course, my wife says I just drink colored water. I'm from the north. We don't drink sweet tea. All right, continue on. If you have a tracheostomy or ileostomy, in other words, you're going to have that little I forgot what that thing is. It collects the colostomy. Thank you. I could not think of that. A colostomy. Okay, you're going to have continuous fluid loss through these openings. All right, Poor hydrated or edematous skin is very fragile, so if they're dehydrated, they have that turgor, you can tear the skin, literally, just like a piece of paper. So you got to be careful on how you handle patients. Which brings up the point where gait belts come in handy, not only for safety, but to keep you from having to grab body parts. I'd rather hold on to a gait belt than grab the arm, and next thing I know, I got a fistful of skin. Also, education is important, how to don and don off. I hate that word. Take on and take off. Embolism stockings. Anybody ever try to put those on? They're bare to put on, boy. Those things are so tight. But once you get them on, they feel good. If you haven't done it, I'm going to have to get some from the hospital so you can just try them on. They feel great. Jeremy, every time he comes to work, he's got them on his both legs, his arms. He tried to put one over his head, but they thought he was a robber. All right, so then you want an elevation. Even though those beds, you ever see a hospital bed, it can raise up here, but it raises the knees, but their feet are still down. So it's best to lay the bed flat and put pillows underneath those. But you want to have the legs at least heart level, maybe a little bit elevated. What we tell patients at home, literally, find 2 nice-sized books and put them under the foot of the bed on either side. That'll raise the bed up so when they lay down, they have it there. Avoid crossing the legs or putting pillows underneath the knees. We talked about that. That's where your knee is just slightly bent, which means your foot's going to swell. And then cross your legs. Of course, when you cross your legs, you cut off circulation in that aspect. Whew. Okay. How many more slides I got?
6.
Really? Yes. Oh, I forgot my watch today. It's only 10. What time does this class go to anyway?
11.
11?
Yeah, 11. He goes to 11.
Well, then you get a present. You get to leave early. But I'll tell all the full-timers, your test tomorrow's a bear. I told you in lab, it's easy.
You got 100.
I took it. Your first pathology test, I write the test questions, then I take it. I don't look up the answer, I just take the test and see what I get. And usually I score anywhere between 99.5 and 100. So. You're all going to be fine. Nobody's in here allowed to fail. And I want to work my tail off to make sure you don't fail. But if you do fail, come see me. The first test. You have 4 chances, so I always tell people, try to do at least good on the first test. That way you don't dig yourself out of a hole. This class is graduating now. This one little girl who sat where Promise is right there, she decided on her first test, she scored a 58. See, you can imagine how hard it is to dig out of that for the last 3 tests. You're going to have to score at least 80 to 90 to bring that up. So try to score good on that first test.
Did she graduate?
Yeah, she's in clinic. She's fine. She busted her tail. And she ended up with a class average of 79. So it's easy. It could be done. The main reason I'm saying that is make your life easier. And don't change your answers. Go with your first gut. How many like to do that? Take the test and go back and review all the questions. Don't do that. Especially in physical therapy or this kind in medicine. Because you're going to have like A, B, C, and D as an example. There are going to be the 2 that are totally wrong. There's going to be 2 questions or 2 answers that are correct, but one is better.
So do we get half credit?
Why do you think it's better?
So therefore, that's what we tell about. You get rid of those 2, and you say, well, this one looks good. You pick it. Sorry. You pick it. And then you go back and change it. Don't do that, because you got it right. So how many of you in the past have changed your answers and found that it was wrong?
Oh,
There you go. God. don't have to treat you like a bunch of mice. You know, put a little piece of cheese here so that you walk to it and get it. Don't change your mind. I was way back in high school. Did you experiment with mice? Yes. Dissect a frog. Dissect a human. Those are great. I mean, someone who can cadaver to walk in there and don't get
Are those the people that fail?
No, those are the ones who live in easily.
Hey. Hey.
All right, so now we talk about fluid electrolyte imbalances. I'm going to get more specific. Your acid-base disorders. How many have swimming pools? How many have to keep checking? You have to keep checking the water for the acid-base imbalances and so on and so forth. Well, your body's the same way. So we go back to the idea of metabolism. Remember that on slide 1 or 2 or 3? Well, we're back there. So the process of metabolism is regulated by the endocrine and nervous system. Those have to work. So if you have a nervous system disorder, your metabolism doesn't work. If you have an endocrine problem, your metabolism doesn't work. So we got to be careful with that. So, plus the rate of metabolism can be influenced. So if someone has a problem, or even if they're healthy, you're just working on a knee replacement, you want to keep in mind the body temperature. You don't have to take their temperature, but it's on the charts. You can look it up and say, okay, they're running a little higher, they're running a little low. The hormone activity. And then the digestion activity. Are they constipated? Because that's going to mess with their metabolism. And if it's messed up, they're going to have energy, so you're going to have a tough time treating them. So, if the fluid or acid-base balance is compromised, it can alter this function we talked about also. So even these control the metabolism, but that's the biggest problem there, is if you have a fluid, you're hypokalemic, etc., or you have an acid-base imbalance, it's going to affect your metabolism. The fancy word for you as therapists, their energy level is going to be low. So it's going to take an act of Congress to get them to do stuff. So don't take no for an answer. So you can have a metabolic alkalosis or alkalosis above 7.45. Everybody knows that 7 is kind of a mean number there. So if you're above 7.45, there's an increase of bicarbonate accumulation or an abnormal loss of acids. Something's going on. Truth be told, I mean, if you get a stomach ache, you feel nauseous, you take antacid. Well, that's a bicarbonate, and that's going to mess up the stuff. So, the etiology commonly occurs when there's been continuous vomiting. A lot of people come into the hospital, the emergency room, because they've been vomiting so much, so their acid levels are changing. The ingestion of antacids. There's some people just pop them all the time. It's like, I ate something, I'm going to pop a pill. Oh, my stomach's burning, I'm popping antacid. Diuretic therapy. So you would end up with an alkalosis in that case. It could be hypokalemia, which would cause that too. Or an NG tube, or nasogastric suctioning. That's where that tube goes through your nose all the way down into your belly, and they're sucking stuff out of your belly. So that'll raise your pH level. Signs and symptoms, if someone is in that, or is very basic. Nausea and vomiting, diarrhea, confusion, muscle twitching, or cramping. And they'll hypoventilate. In other words, they just don't breathe. They don't get enough oxygen. So you as therapists have to be aware of this. An acidosis, that's below 7.35. So you're becoming acidic. So, well, there's your normal levels there, per se. As a condition occurs when the accumulation of acids are due to acid gain or bicarbonate loss. Your blood levels are changing. So if you look at everybody has, if you went and got blood work, you can look on my chart, and and I highly recommend going and look at your last CBC, because now you're starting to learn this stuff. Just out of curiosity, you can look at your acid base balance. All right, what causes you to become acidic? Renal failure, lactic acidosis. I always think about that way. You know, you get lactic acid when you exercise. There is such a thing as over-exercising. You can exercise so much, and your marathoners in the Olympics, there was several incidences where the people who ran it ended up with metabolic acidosis because they just exercised or ran too hard, too fast, and what have you. Starvation, which is why we tell patients to eat. Diabetic or alcoholic ketoacidosis. Too much acid in that. Severe diarrhea. For you wise and future wise, poisoning. Hard to detect. All you do is say, I don't know, they have acidosis. It could be because they have severe diarrhea. They don't look for the poisoning. Hint, hint, hint. No, I'm just kidding.
But you deserve it. That's the question.
All right. So there's the etiology, and here's some of the signs and symptoms you'll see if you have too much acid in you. And the one that's mainly concerned is your cardiac arrhythmias. Their heart rate's just not working correctly. All right. Oh, by the way, this one, and this one are the big three. There's a whole bunch more, but I just cut it down to just three slides or three things that you have to know. So with respiratory acidosis, that's carbon dioxide retention. How many hyperventilate and they breathe into a brown bag, paper bag? That's the old way. And they still do it in the hospital. If someone's hyperventilating, they just put a bag over their mouth and they have them breathe to get the carbon dioxide in there. But if you get too much carbon dioxide, anybody sucked on the tailpipe of a car? No? Has anybody clogged the tailpipe so that they can send stuff into the car? So with the respiratory acidosis, you have too much carbon dioxide. Here's some of the causes. Burns. Burns are huge. I'll tell you this story all the time. The funniest guy I ever had came up from the Augusta Burn Center because he was so drunk and he didn't want his wife to know that he took the case of beer empties, took it to the fire pit, dropped it in, flame shot up, he passed out in the fire pit. I'm sorry, that was funny. Because he's alive, so it's okay to laugh. But anyway, so he had a lot of respiratory acidosis for the longest time in there. Chronic pulmonary diseases, if you have heart problems. Nobody in here has heart problems. You do? Heart defect? You have a heart. Good. What kind of defect, may I ask?
Enlarged.
Oh, you exercise too hard. Be a slug. All right, drugs or over-sedation will do it. Drug users, IV drug users. A lot of people think, one pill worked good, I'm going to take two more. So they sedate themselves. And then you as therapists are going to look for dyspnea. What is their breathing? Are they puffing and puffing? You'll learn the dyspnea scale, which is basically how many breaths you have to take to count to 15. Some people go 1, 2, 3, take a breath, 4, 5, 6, 7, have to take a breath. So they're going to get that scale there. So when you're walking someone and they're panting, just have them stop and have them count to 15 and see how long it takes them to get to that. And some of you probably can count to 15 in one breath. You'll be cyanotic. HA, get used to that. It's headache. And you'll be disoriented. But all this stuff is kind of common sense. If you can't breathe, that's what's going to happen to Now, you as therapists, here's what you're going to be dealing with. Rehabilitation considerations are recognize the higher risk populations for imbalances with patients. So, if you're going to be working with renal disease people, you're going to have these acid-based disorders, everything from alkalosis to acidosis to respiratory problems. Cardiovascular pulmonary disease, I think that's the whole world right now. I've treated more heart problems. I've been down here too long. I don't know if it's just the South or just everywhere, but it just seems to me when I moved down here, everybody had heart problems. That's for me to have fat back, right? Burns, fever, people have the flu, sepsis. I put that in here because you're going to have to understand sepsis, not only for education-wise, but for real life. Sepsis basically is an infection that gets into your bloodstream and spreads throughout your whole body. So that's sepsis. Then you become septic. That's when your entire bloodstream is full of bacteria and it starts shutting off your internal organs. So you become septic. So if you see anything on a diagnosis with sepsis, be extremely careful. Someone who's on vents, you'll see that in ICU. If you get a chance, when you get your clinicals, work in the ICU. It's great. And the reason I say that is, there's where you have to sit down and use your brain a lot. All this stuff we're talking about, a lot of it has to deal when you're working in the ICU units. In Mercy Hospital in North Carolina, literally has set up a physical therapy department in the ICU clinic. That's all they do. They're in the ICU because they found out through research, the more someone's in ICU moves and exercises and such, the faster they get better. So I think it's a great idea because, if you're ICU, they're going to die and they're really sick and stuff like that. No. They're sick because they're not doing anything. Diabetes is bad, or enteric drainage. They could be draining from the IV. They could have a bed sore that's draining, something of that sort there. So these are your high risk populations, and yes, you will be treating someone that's high risk. All right. So recognize the signs of dehydration in a diabetic patient. Diabetics get very dehydrated. So you want to be aware of that. Injury prevention during involuntary muscle contractions, secondary to the metabolic alkalosis. What that simply means is involuntary, they may do you just got to teach them more than anything else when they do an involuntary muscular contraction. You don't want them to do something and they do it, or they're twitching and so on and so forth. Recognize that patient during diuretic therapy for potassium depletion. So you know about potassium, what it does. So if they're having diuretic therapy, the potassium's going to go down. It's true. Give them a banana. It works. But the point is, though, go back to those previous slides. What happens if you're low with potassium? Your muscles aren't working. Then recognize that Trousseau's sign during blood pressure measurements indicates calcium deficiency and early stages of tetany. Basically, what that means is when you put a blood pressure cuff on, you start pumping it up. What they're gonna have this Trousseau's sign. In other words, they're gonna kind of do this. In other words, they may start twitching at their wrist, coming up and down, only because you're kind of putting a blood pressure cuff on. So that's an early sign that they could have calcium deficiencies. Which brings up the point, why do we do vital signs before you treat? It's going to tell you a lot of stuff. It's going to give you a warning of what to expect when you're doing your treatment. And I'm done. Any questions?
Yes, but not about this.
Yes, but not about this. Your test tomorrow is going to be simple. You're all going to pass.